So let us discuss the management approach of a lupus case. It will be difficult, as all lupus cases are, or most lupus cases are, but it can be a case that you can see in your clinics quite often. Next slide, please. This is the case of a 34-year-old white Caucasian woman with a 10-year history of lupus that was admitted to our hospital in Barcelona because of paresthesia in her left arm and speech difficulties. The diagnosis of lupus had been made at the age of 24 based on cutaneous manifestations, mainly malar rash, photosensitivity, joint involvement, arthritis, oral ulcers, and autoantibodies, the detection of antinuclear, anti-DNA, and anti-SM antibodies. At that time, other antibodies like ENA and antiphospholipid antibodies, lupus anticoagulant and cardiolipin antibodies were negative at diagnosis. And she was treated with hydroxychloroquine at the time, 200 milligrams a day, low to moderate doses of prednisone and methotrexate, 20 milligrams a week. So in addition to this lupus history, other relevant past history included the diagnosis of another autoimmune disease, hypothyroidism due to autoimmune thyroiditis at the age of 18, and this was treated with levothyroxine. And she had at that moment no pregnancy history. Next slide, please. Lupus nephritis was diagnosed just 1 month before the current hospital admission, and we performed a kidney biopsy, and the kidney biopsy disclosed a class 4 lupus nephritis with an activity index of 8 out of 24 and a chronicity index of 1 out of 12. Next slide, please. And then, as you may remember, the patient was treated at the time mainly because of the cutaneous and joint involvement with methotrexate. At that point, methotrexate was discontinued, and then lupus nephritis induction of response therapy was started at the hospital with 3 daily pulses of methylprednisolone, 1 gram each, and low-dose pulse cyclophosphamide. We use the Euro-Lupus regime. And she was advised to continue on hydroxychloroquine, 200 milligrams a day, and 30 milligrams a day of prednisone. Next slide, please. And then just 1 week after the administration of the first pulse of cyclophosphamide, was the Euro-Lupus regime, 500 milligrams, the patient presented acutely with numbness and paresthesia in the left arm and hand, as well as speech difficulties, and was admitted to the emergency room. At physical examination, dysarthria and paresis of the left upper limb were confirmed, and the blood pressure at that moment was 170 to 95 millimeters. Next slide, please. So at this moment, we thought that different options could happen at this moment. The differential diagnosis was put into question at that moment, including hypertension, essential hypertension. Actually, the patient had hypertension, and maybe this was just a hypertensive crisis, or maybe it was a transient ischemic attack, just started, or a stroke, or a vasculitis, cerebral vasculitis, or an encephalitis, or even a Press syndrome. And I wanted also your opinion. Maybe Manuel, you want also to give your opinion.
Thanks, Ricard. Well, I would think about probably stroke or transient ischemic attack. I would like to ask you if the patient had a nephrotic syndrome or just a mild proteinuria, thinking of the probability of thrombosis.
The patient had around 1 gram proteinuria in 24 hours urine collection, 1 gram. So no nephrotic range, no nephrotic clinical manifestations.
And she was adherent to the treatment because the patient received antimalarials, at least officially, but maybe she wasn't taking the drug.
That's an important issue, really. We physicians are very aware that many patients are not adherent to treatment. And this is, in many occasions, the main reason that they don't respond to therapy. She accepted, or she said that she was taking the treatment. And we can accept that she was certainly receiving this treatment. Well, I don't know if anybody else wants to give an additional opinion. If not, next slide, please.
Did some neuroimaging?
Later, we will do this. This is what I propose at that moment, is to perform either just some blood test, renal test, also some autoantibody detection and complement levels, or a lumbar puncture, or an imaging technique, a brain CT scan. I don't know, Laurent, do you want to give your opinion what to do at the emergency room? We are still at the emergency room.
I understand. And I guess this is why you have the option F of a brain CT scan. But we all know that, especially in young persons, I mean, the best imaging technique is the MRI. So maybe we cannot get it as an emergency, but if there's a suspicion for stroke, and maybe that's the case, I would enforce, at least in the list, the possibility to get an MRI, not just a CT scan.
I agree. But actually, next slide, please. We started performing some lab tests. We found that the ESR erythrosedimentation rate was slightly high, 25 millimeters. C-reactive protein was just very slightly high, 1.2, being normal below 1. Creatinine was normal. The urine sediment at that moment was normal. And the lab sticks for proteinuria just at the emergency room was certainly positive. Next slide, please. And we performed the brain CT scan. Just at the emergency room at that moment, it was possible to perform quickly the brain CT scan and actually show a cortico-subcortical hypodense lesion at the right frontoparietal region that was considered as an acute ischemic infarction. Next slide, please. So at this point, we have to give some treatment at the emergency room. The patient was still there. And there were several options, the immunosuppressive therapies, pulse methylprednisolone, or the pulse of cyclophosphamide, give anticoagulants, or give antihypertensive drugs, or even probably do much more sophisticated therapies such as plasma exchange. I don't know, Manuel, that you proposed before one of the diagnoses that probably this was the final diagnosis. What do you propose at that point?
Probably anticoagulants, antihypertensive drugs, depending of the blood pressure, because we don't want to reduce it too much. But at least when the patient arrives to the emergency room, she needs some antihypertensive drugs. Aspirin. Probably I will wait for the antiphospholipid antibodies, because if the size of the lesion is big, so I would expect a smaller lesion in the CT scan.
Okay, perfect. Thank you very much. Next slide, please. And certainly the patient was treated with antihypertensive drugs, enalapril, and anticoagulants, enoxaparin. And during the following week, the patient experienced improvement in the speech and the disappearance of the left arm paresthesia. Next slide, please. And then we have to do something else, probably in order to assess which was the etiology of these lesions. We can do additional autoantibody testing, anti-DNA, complement for lupus, anti-P ribosomal antibodies, anti-neuronal, antiphospholipid, so more brain images, carotid ultrasound, echocardiography, brain MRI. I don't know, Betty Diamond, that you are an expert on neurolupus. Probably you can give your opinion, which is the best test, maybe which is the best antibody to test at this moment.
Oh, I think you want to test antiphospholipid antibodies because they're the ones that are clearly associated with her pathology. Can I ask you another question?
Yes, of course.
Do you feel in retrospect that you should have done brain imaging when she first presented?
Yeah, actually, this was done just very short after the emergency room CT scan. Anyway, but first it was done the CT scan. That is the image that I show you. Okay, yes, thank you very much. Next slide, please. So we tested for the antiphospholipid antibodies, and the patient was triple positive at that moment. Remember that in the past we assessed the antiphospholipid antibody status, and it was negative at that moment. But at this moment, the patient was lupus anticoagulant positive, and also IgG and anticardiolipin, anti-beta-2 glycoprotein antibodies were positive. And we assess also other atherosclerotic features by means of carotid ultrasound that was normal, and the echocardiography just found my mitral thickening, really very, very mild. And the final diagnosis was antiphospholipid syndrome associated to lupus. And then we decided to continue the oral anticoagulation, but to switch to acenocumarol in a long-term basis. And this was due to the fact that we made the diagnosis of this antiphospholipid syndrome as the cause of the stroke. Next slide, please. And I wanted to stress this case because this is a potential relatively common complication in patients with lupus, the presence of the antiphospholipid syndrome. These are the main publications of classic epidemiological studies that we performed several years ago. The Euro-Phospholipid project, we gathered 1,000 patients from all over Europe and with the antiphospholipid syndrome, and we follow these patients for 10 years, and we learn a lot of things from the clinical point of view regarding the antiphospholipid syndrome. And we know that around 30 to 40% of the patients with lupus develop the antiphospholipid syndrome. Regarding patients with antiphospholipid syndrome, approximately half of them have a primary antiphospholipid syndrome, and the other half have associated lupus. Next slide, please. And the main clinical manifestations certainly are deep venous thrombosis that can appear over the years in more than 50% of the patients, pregnancy morbidity, thrombocytopenia, but stroke is also an important clinical manifestation. It's the most common arterial thrombosis in the antiphospholipid syndrome. Next slide, please. When we analyze specifically in this Euro-Phospholipid project the neurological manifestations, actually the most common, although probably it's a little bit complicated to say if it is really related to the antiphospholipid antibodies or it's just associated, is the presence of migraine, although these patients with antiphospholipid antibodies usually have a more severe migraine. Then is a stroke that appears in approximately 20% of patients with antiphospholipid syndrome, and then transient ischemic stroke. Other neurological manifestations are epilepsy, multi-infarct dementia, venous thrombosis in the brain, encephalopathy, and so on. So it's important that in addition to lupus and the inflammatory manifestations and the type 2 manifestation related to lupus, patients can present other autoimmune diseases associated, being the antiphospholipid syndrome, a very common associated autoimmune disease in patients with lupus. Thank you very much.
Could I ask, Ricard, before you leave, here the trigger for the antiphospholipid syndrome was probably her active lupus. So I agree with all the treatments you prescribed for the antiphospholipid, but what do you do? What happened with her lupus? Were you able to get that under control?
Yes, we managed to control. We continue with the lupus regime with pulse low dose pulse cyclophosphamide. Then we switch to azathioprine, and we taper the steroids. We continue also with hydroxychloroquine, and the patient have a complete renal response. So lupus went well, and also the antiphospholipid syndrome. This is a patient that this happened something like 10 or 12 years ago, and the patient has not had any other thrombotic event after these years, and oral anticoagulants. And at this moment is in complete remission of lupus.
The 200 milligrams that you used for hydroxychloroquine, was that appropriate for her weight? Or, I mean, that's a low dose.
Yes, it was a small, relatively a small lady. And this is the classic tablet. So we decided to continue with the standard one single tablet. It's 200 milligrams.
Can I ask a question, please? When she was diagnosed with lupus nephritis, you treated her with pulse steroids. What happened to her blood pressure at that time?
Actually, at the moment that we gave the pulse methylprednisolone, there was not an increase in the blood pressure. It was It was a couple of weeks later when we continue with cyclophosphamide. It was several days after the first pulse of cyclophosphamide. The cyclophosphamide was prescribed the fourth day.
And so she never had a history of hypertension, is that correct?
No. She had not a history of hypertension in the past.
And were the antiphospholipid antibodies checked when she was diagnosed with lupus nephritis?
Yes, but at the kidney there was not lupus nephropathy. So, and there was not any other, for instance, thrombosis of the renal artery or in the venous artery, renal venous. So this was just a stroke without any other manifestation of the antiphospholipid syndrome, and maybe the stroke produced reactive hypertension that actually also was easily to control.
Okay, but again, my question is serologically, were the antiphospholipid antibodies tested when she was diagnosed with lupus nephritis? And
it was tested several times during the past 10 years, and I think that just the previous one before the stroke was something like 6 or 8 months before, and the antibodies were negative at that moment.
So if someone can enlighten me, when we talk about antiphospholipid syndrome, for how long do you have to be serologically positive for the presumed biologic effects of these autoantibodies to, lead to whether it's venous or arterial clots?
That's one of the mysteries of the antiphospholipid syndrome. We don't know for how long, but what we know is that if they have more antibodies, for instance, what I stressed that the patient was triple positive, presented the 3 classic standard antiphospholipid antibodies, the lupus anticoagulant, anticardiolipin, and anti-beta-2 glycoprotein 1. All three were positive. We know that these patients that have all three antibodies positive that have a higher risk of thrombosis. Also, we know that lupus anticoagulant per se is a high risk. IgG, isotype, is a higher risk that IgM. So we know this. Also, we know that those that are persistently positive that are at a higher risk. But also, there are patients that we discovered this for the first time, and they produce a clot. And also, we have seen patients with IgM, anticardiolipin antibodies, that statistically is less prothrombotic with a catastrophic antiphospholipid syndrome. So, although, let's say, statistically, there are some group of patients that have a higher risk, triple positive, lupus anticoagulant, IgG, persistently positive antibodies, there are exceptions.
Okay, thank you very much.